Welcome back to the deep dive. If you are prepping for your board certification, this is for you. We're going to jump straight into the foundational science of surgical suturing.
That's right. The mission here is to distill this down into concrete, memorable insights. Not just listing facts, but understanding the why.
The why. I like that. So let's start right there with technique. Okay, let's unpack this. When we're closing skin edges, what is the single most important technical goal we are trying to achieve for, say, the best possible scar?
The word you need to own is aversion. A successful closure, a really beautiful closure, demands that you evert the skin edges.
Avert them, so roll them slightly outward.
Exactly. If you remember nothing else, remember that. The edges have to roll out.
So why is that? I mean, what's happening on a physiological level that makes that better than just, lining them up flat?
It really comes down to dermal apposition. By averting, you're ensuring the deep living layers of the skin are brought together perfectly.
Ah, so it's a deeper level alignment?
Precisely. If you close flat, or worse, invert the edges, those deeper layers can end up with a gap or get misaligned.
And what does that perfect deep alignment get you in the long run?
You get much improved healing dynamics. And crucially, you avoid that sunken look. When a scar depresses and widens over time, eversion stacks the odds in your favor for a finer, flatter, final result.
Okay, so eversion is goal number one. Let's talk about the enemy of all good scars. Tension. How do you prepare a wound, especially a high-tension one, before those final skin stitches even go in?
You have to address tension deep down. It's that simple. For almost any wound, you start by opposing the deep dermis with dermal sutures.
So those are the real workhorses?
They are the workhorses. Absolutely. They take on the entire mechanical load.
And what does that do for the superficial layer?
Two things. First, it dramatically reduces the tension on your cutaneous sutures. So those top stitches can just focus on fine-tuning the eversion, not holding the wound together. And second, it limits the stretching of the wound as it heals. If you only rely on the surface stitches, that scar is going to stretch and widen over time. It's inevitable.
Okay, that's a perfect foundation for a technique. Now let's get into the materials. There are so many choices. How do we even start to categorize them? What are the fundamental axes?
It's actually pretty straightforward.
Yeah.
Every single suture can be mapped along 3 distinct axes. If you know these, you have a mental map for everything.
Okay, what are they?
1. Is it absorbable or non-absorbable? Does it go away or does it stay?
Simple enough.
2. Is it synthetic or natural in origin?
Okay.
And 3. Is it braided or monofilament? And this structural difference is really key. It affects everything from handling to infection risk.
That third one, braided versus monofilament, sounds like something we'll be coming back to.
We definitely will.
Let's dive into the absorbable sutures first. All right, let's start with the classic, the one that's been around forever, catgut. What is it actually made of, and what's the issue with its absorption profile?
So catgut is derived from intestinal layers, either bovine serosal or ovine submucosal. And its major drawback is that it's a natural protein.
Which means the body sees it as foreign.
Exactly. It elicits a really significant inflammatory response, which is never what you want for clean healing.
And what about its timeline? I hear it's unpredictable.
It is. It loses its strength in just 8 or 9 days. And full absorption can take 2 to 3 months, but that process is enzymatic. It's just not reliable.
So what about chromic catgut? How does treating it change its behavior?
The chromatization process, it sort of hardens the suture with chromic salts. This decreases the absorption rate. It just slows down that enzymatic breakdown a little.
Okay, a little more predictable. And even though it's not used much in places like the UK anymore, where might it still pop up on an exam?
You might see it used for mucosal sutures, maybe a dermal suture in the face where you actually want that early strength loss, and sometimes in children for skin closure to avoid having to remove stitches.
Right. Let's pivot to the modern workhorses then, the synthetic polymers. Let's compare polyglycolic acid dexin and polyglactin 910 Vicryl. How do they stack up on timing?
They are, for all intents and purposes, twins on the timeline. Both are degraded by hydrolysis.
And hydrolysis, just to be clear for everyone, is a predictable chemical breakdown with water, not that unpredictable enzyme process like catgut, correct?
That's exactly right. It's a chemical clock.
Yeah.
So for both Dexin and Vicryl, you're looking at strength loss by 21 days.
Yeah.
And they're completely gone by 90 days.
So if the timing is identical, what's the big difference? You mentioned structure earlier.
The structure. Vicryl is a braided synthetic. And that braided structure, well, it can be a problem.
A problem how?
The little spaces between the fibers in the braid can create niches for bacteria to colonize. It gives them a place to hide from the immune system.
Ah, so a higher infection risk than a smooth suture.
Potentially, yes.
Yeah.
It can also provoke a bit more of an inflammatory reaction than a monofilament.
And Vicryl has variations, right? Vicryl Rapide and Vicryl Plus.
It does. Vicryl Rapide is for ultra-fast absorption. It's lost its strength in just 7 to 10 days.
And Vicryl Plus.
That's the one coated with triclosan. It's an antibacterial and antifungal agent designed to mitigate that colonization risk we were just talking about.
Which makes perfect sense. So what's the monofilament alternative here? Polyglucoprone 25 or monocryl?
Monocryl is your monofilament synthetic, and because it's a single smooth strand, it is fundamentally less prone to bacterial colonization.
So in a potentially contaminated wound, monocryl might be a better choice.
That would be the thinking, yes. Otherwise, its absorption profile is very similar to Vicryl. And yes, it also comes as Monocryl Plus, coated with triclosan.
Okay. Last one for the absorbables. What if you need something that lasts much, much longer? For closing fascia or a wound under high tension?
That's where you reach for a polydioxanone sulfate, or PDS2. This is your slow burner. It's a monofilament that's absorbed much more slowly than Vicryl or Monocryl.
And how slowly are we talking? I know the strength loss is size dependent and comes up on exams.
It is, and it's a critical difference. Within 6 weeks, a 3O PDS loses about 40% of its tensile strength.
40%, okay.
But a 4-0 PDS, the smaller one, loses 65% of its strength in that same time frame.
Wow, that's a huge difference. So the caliber really matters for how much support you can expect, and when is it totally gone?
Fully absorbed by 6 months, which is why it's the go-to for dermal sutures in areas prone to stretching. It provides that mechanical support for a very long time. And of course, there's a PDS Plus with triclosan as well.
Okay, that covers everything that disappears. Let's move on to the permanent stuff, the non-absorbables. What are the two main applications for sutures that never dissolve?
Well, you use them in 2 very different ways. The first is for cutaneous stitches, the ones on the surface that you have to take out later.
Right, the simple skin closure.
This simple skin closure. And the second is much deeper to provide permanent tissue fixation. Think orthopedics, vascular surgery, places where you need that strength forever.
Okay, for board prep, we need the examples. Let's split them into natural and synthetic.
The natural list is very short these days. You're basically talking about silk and cotton.
And the synthetics.
That list is much longer. You have polyamide, which is nylon, polypropylene, which everyone knows as Prolene. Then you have the polyesters, like Ethibond or Novafil.
Okay.
Then there's PTFE, which is Gore-Tex.
Mm-hmm.
And finally, you have stainless steel.
Quite a range of materials there, from flexible Prolene to, well, steel.
It really just highlights the different needs for permanent internal fixation. Hashtag tag outro. So if we pull it all together, you have catgut with its inflammatory, unpredictable profile. Then you have the 90-day synthetics, where the big fight is Vicryl's braided structure versus Monocryl's monofilament smoothness. And PDS2 is your 6-month player for high-tension zones.
So we've covered a ton of ground, from achieving adhesion to managing tension, and then charting the lifespan of all these different threads. So here's something to think about. When you look at that list of synthetic non-absorbables, nylon, Prolene, polyester, PTFE, and stainless steel, and you think about using them for permanent fixation in really high-stress areas like a sternal closure, what inherent property of stainless steel might make it the absolute definitive choice over all those polymers when you need unmatched long-term mechanical stability? It's something to mull over.